many of us are on black alert. And Kareem is recording the message. I assume you're okay with that, Sarah? It's really good because then we can record this and put it on YouTube on K-Miran2 as YouTube channel, and you can go through and find as many videos there, and they'll be on catheter-directed thrombolysis. But if you need a quick recap on this, which I think is going to be really important for a small minority of patients, then it might make a big difference. So it's great. With great pleasure, I'm going to introduce Dr. Sarah Robbins, who's one of our palliative care consultants, who I've had the pleasure of working with for the last few months, and has really helped me and my patients with some really difficult cases. One of the things we saw in the first wave of COVID was a lot of patients who died from COVID. And it was clear and apparent that our standard palliative care protocols perhaps wasn't sufficient to help those patients. And with an expected wave about to hit us imminently, we thought it would be good to go through our guidelines, the amended guidelines that we use for patients with COVID who are dying. It's really great that a lot of you have got your cameras on. The AMU team are desperately trying to turn off the camera, but could I ask anyone if they could, if they turn the cameras on? It's just so much more easier for the speaker, they can see people. And without further ado, I'll let you start, Sarah.
Thank you, George. This is going to be a little bit on the hoof, everyone. I was told it would be 5 or 10 minutes, but now I've been told I've got a bit longer. So hopefully that means we can get down to the nitty-gritty a little bit more and cover some of the things that you struggle with. So before I start, what I might just ask everyone is, one, if you have seen patients dying from COVID in the last wave, what were the challenges that you had last time? So what are the things you struggled with, and what are the key things you want to get out of today? And then two, just before we started, George also mentioned to me that so far they're seeing patients dying in a slightly different way to the last wave. So maybe just any comments on that. So far, we've got a message from Ben saying, managing very distressing breathlessness. Yeah, that was a really key thing. Do feel free either to write in the chat or to speak. Dying without family members present. Yeah. How to best manage with family members, how to best engage with family members. Yeah. By that, do you mean when you can only speak to them on the telephone, or maybe just clarify that a little bit? So lots of people writing stuff in the chat here. Dying on CPAP, general fear around COVID, knowing when to both actively treat whilst also offer comfort medications and care, difficulty with visiting policies, family understanding how a frail vaccinated patient could still deteriorate despite this, wearing PPE and trying to express compassion. Yeah, these are all really common things that I think all of us have experienced. And just to come back, George, I wonder if you could just say a little bit about your experience so far during this wave of what you've seen with people dying or not dying.
Actually, so what I was going to say is that we're seeing far less patients dying due to COVID this wave. And that's thanks to all the great help and support we're getting with the COVID treatment group in terms of tocilizumab and all the new drugs. So the patients I have seen die have died quite suddenly, actually. And I think perhaps last time we saw patients have a very prolonged dying pathway. My experience in acute medicine, bear in mind that patients don't spend a long time here. So I'd really value the opinion of the 4 South and 7 West doctors, or any of the other doctors who see people perhaps longer. This has been relatively fast, so fast that we have not actually been as prepared or prepared the family for what was going to happen.
Is there anyone from Respiratory or 4 South on here?
Yeah, can you hear me?
Hi, Brendan.
Hi, sorry, I'll put my camera on. Sorry, I'm trying to do more than one thing at the same time. Yeah, so I am from Respiratory. I think I'm seeing less die, so the first wave was more on CPAP and that was all full. it's awful to start and it's awful to stop, because the family thing that's kind of that stopping it equals death automatically, and that you've given up on them, and that it's that you're kind of actively killing them by stopping the CPAP. So that was what was hard in the first wave. So it's always easier to start, but really tough to stop. The ones I can't say I've seen, I've seen one in this wave. I've seen one or two kind of die on high flow, and we managed to wean them off. And then it's been the ones which have shocked me, I think, is one 32-year-old in particular who stepped down from ITU on 60% and then just arrested after mobilizing. So yeah, a little different at the moment, but
yeah, and so I guess some mirroring with George's experience of people dying very, very suddenly.
Yeah. Well, there only
only
one I've seen like that.
Yeah.
But it was very shocking, obviously.
Yeah. And I guess, so I think our experience as a palliative care team has been very similar. So yes, huge challenges, lots of uncertainty about whether someone's going to die or not, and then people acutely dying. And then, as someone said, I think the first comment we had was about how people die, so terminally agitated or terminally breathless, which can be a very tricky symptom to manage. And then all the challenges of visiting and all the rest of it. So I was just going to share my screen now. I've got a few slides to show you about end-of-life care. So all of this information is on the intranet. And that is the first thing I'd like to point you all to. And maybe if you're working somewhere where you see a higher number of patients dying, it may be worth having a look through the guidance in a bit more detail. Can everyone see my slides? Yeah, great. So the key things I wanted to just talk through were, one, the mini guidelines we've got for patients who are dying of COVID-19. Two, how to prescribe a syringe pump, because some of you may never have done that before. And when you're in a rush, when things are very busy, it's hard to kind of find where the guidance is. So I just wanted to kind of go through that, and we can, because we've got a bit more time, I might actually get Cerner up and prescribe a syringe pump for you so you can see exactly what to do. I'm not going to talk about this in detail, but there are guidance around managing symptoms on someone who has CPAP, so managing things like agitation, breathlessness, delirium, both in patients that we're treating actively and in patients that are dying and we're withdrawing off of CPAP. I'm just going to talk briefly about the care agreement, which hopefully everyone knows about but may not be using, so just to remind everyone about that. Just to say that there's a communication guide which you should definitely print off and have available, because it's got some really nice key phrases, and one of the things that people were writing in the chat was about difficulty communicating with families, so this might help. And then also just to point you towards some education modules if people did want to learn a bit more, and to say that we have, the end of life team have developed some leaflets for family and patients. So we've now got a care in the last days of life leaflet, which people might find useful, and also a new DNA CPR leaflet. So the end of life mini guidelines, here they are. When you go on the internet to the end of life care page, there are much more detailed guidelines for kind of general end of life care. The idea of this guideline was that it would just be something really quick that people can access when they're very busy. So you might want to take a picture of this or go onto the intranet and make sure you've got it available so that you can reference it very quickly. A few key points to make. So when in this trust we don't use ranges, although it says 2.5 to 5 milligrams, the aim was that you'd either write 2.5 or 5 milligrams. If someone's in very severe pain and are needing a higher dose, then you'd write 5, but for most patients we'd be starting with lower doses of 2.5, unless someone's already on a background of opioid already. So for example, if someone's on a fentanyl patch, or they're on some modified release morphine at a higher dose, then we'd need to work out what their breakthrough dose should be by dividing their background dose by 6. But otherwise, these are the starting doses that we use. So don't write a range, just write one number, and the starting dose should be the lower number. And that's the same for all of these drugs. But this is something that would be really, really useful for you to have at the tip of your fingers if you need it for someone that's dying of COVID. And then just to say that in terms of prescribing anticipatory medicines, there's a really great chart on Cerner where you can do this very quickly. So rather than having to prescribe, type in morphine sulfate, type in midazolam, you can type in to orders end of life, and then it comes up with PRN medication, and then you just tick the drugs that you want. And I can show you on Cerner in a minute if that's useful. You then put in the dose of the drug and the frequency of the drug, but this does make it a lot quicker. So the other thing that I'm going to show you is how to prescribe a syringe pump. And again, that's through orders on Cerner. There's kind of very clear guidance on how to do this again on the end of life intranet page. There's a kind of step-by-step guidance. But what I'd recommend is that for people who haven't done it before, maybe just practice on a test patient. It should only take you a few minutes, and then it'll be much easier to do in real life when you have to do a syringe pump. The other thing to say is just make sure you let the nurses know that you're prescribing a syringe pump, because they need to request the pump from the equipment store. So I might just see if I can share my Cerner screen with you. So I'm going to stop sharing the presentation. Hopefully you can now see Cerner. Yep. So let's start with, so if we go into orders, and then type in end of life, and go to a subcutaneous syringe pump. I've got Zoom in my way, so I can see everyone. There we go. Let me get rid of you. So once you have kind of prescribed the syringe pump, if you go to orders for signature, this box is just telling you that interaction checking isn't done on Cerner. So you can put more than one drug in a syringe pump. So for example, we very commonly put in morphine and midazolam together, or morphine, midazolam and glycopyrronium together. And we know from our experience that those drugs mix well, but Cerner doesn't do that checking for you. So if you're worried that the drugs might not mix, if you're using a mix of drugs that isn't usual, then speak to us because we can check that for you. So once you have put the pump in, you then need to put the drugs into the pump. And you do that by going to additive, so this yellow box here, clicking that, and then you type in your drugs. So for example, if we wanted morphine, and then if we wanted midazolam, so you can do more than one drug at once. So you can put those into the syringe pump, and then you just handwrite the doses where it says additive dose. So for example, you could put 10 milligrams for morphine, 10 milligrams for midazolam, and then to work out the rate, you just need to go to this section which says infuse over and just write 24, because the pump runs over 24 hours. Once you've written 24 there, it will automatically calculate the rate for you. So that's your syringe pump done, and then you click sign. I'm just going to, does that make sense? Did you all see that? Okay, so junior doctors, please have a go at prescribing a syringe pump on a test patient, because as I say, it will make it a lot easier when you have to do it in real life. So moving on to the CPAP guidance. So this is for patients both who are having active treatment continued and patients in the last hours to days of life. So there are 3 algorithms, and it is quite a long piece of guidance. So I would definitely have a read of it in advance rather than kind of looking at it in a more urgent situation. So the 3 algorithms, there's one on the management of agitation symptoms in patients on CPAP who are still for active treatment. So that's breathlessness, anxiety and delirium. And then there's an algorithm for those who aren't responding to first-line treatment. So the first-line treatment tend to be oral options for those symptoms. And if that's not working, you could then look at using a syringe pump, even in a patient who's not dying. And that would be to look at managing their symptoms. And then the third algorithm is on patients who are on CPAP and are thought to be dying, recognised as dying. And that also includes how to withdraw CPAP and what medications to use. The next thing I wanted to show you is the care agreement for the last days of life. Before I talk more about this, I don't know if I can see 6 people on my screen. George, you may be able to see more than I can because I'm presenting.
There are 62 of us.
But can I just check who is actually using this? Does everybody know about the care agreement? George is saying no. I can see Brendan, that's probably no. So lots of people aren't. So
No.
I'll describe it in a bit more detail. This is, so previously we had the Liverpool Care Pathway, which in 2013-14 was kind of stopped because, I mean, people may not have a clear understanding of what the Liverpool Care Pathway is, but essentially it was a piece of guidance to help patients who are dying in hospitals have the same type of level of care as they'd get in a hospice. Unfortunately, the guidance was very kind of tick boxy, and unfortunately some of the guidance wasn't applied as it should have been, and meant that there were some people either who weren't actually dying or who were dying but probably taking a bit longer to die, that didn't get the care that they should have got. And there was a big inquiry into it, and then the Liverpool Care Pathway was removed, and then individual trusts have then developed their own care plan for people who are dying to make sure that we still cover all the very key areas for end-of-life care and make sure people are getting the right care in a hospital setting when they die, but to make it much more individualised rather than this tick boxing exercise that Liverpool Care Pathway had. Just to highlight that one of the key problems with the Liverpool Care Pathway was particularly around things like nutrition and hydration, and there were reports of patients, even when they were still able to drink in their last days of life, not being offered drinks, not being said that, oh no, you're dying, you don't need those things. So that there was this big concern over that. And it was all in the media. So even though it was probably a minority of patients that this happened to, it was very much in the public eye. So at Imperial, our end-of-life team have come up with a care agreement for the last days of life. And so this is for patients that we have been recognised by their consultant as dying. And it's a template for us to fill in on Cerner to document their end-of-life care. So there's one template for doctors to fill in, one template for nurses to fill in when they're recognised as dying, and then there is a daily review document as well. And the care agreement covers the 5 priorities for end-of-life care. So these are kind of national priorities that we have, looking at have we recognised that someone's dying, have we looked at reversible causes, is anything treatable? If not, that we as an MDT are saying that they're dying. 2, have we communicated that the person's dying, both to the patient and to their family, if that's appropriate? 3, have we involved the patient and the family in the decision making? 4, have we offered support to the family? And then 5, have we made a clear individualized care plan? And that will include things like stopping observations, making sure anticipatory medicines are written up, spiritual care, all of those things. So I don't know if it would be useful for me to just get the care agreement up, or George, what do you think? Have we got time?
You know what? I think I would like to see it. I hope everybody else doesn't mind. I think it's.
Yeah, we have time. We have definitely have time.
Okay. Well, I will show you them because although this is active, I think from my experience of the wards, I don't think we're using it very much. And even us as a team, although we're trying to encourage more people to use it, I don't think that everybody's had training in it. So it probably would be useful to do. So I'm just going to stop sharing this and go back to my test patient, who hopefully will still be there.
Yes.
Okay. Now I have to get rid of my syringe pump. So if you go into ad hoc and then end of life care, which is quite near the bottom, there you will find the care agreement. So you tick the box there. So as I say, these 5 priorities are kind of starred, as you can see down the left-hand side. So recognizing that they're dying, communicating it, involving the patient and family, supporting the family, and then your plan. So the first box is, what are the indications that led to the team believing this person's going to die? Is there anything reversible? So you can type in there, it might be, because we're talking about COVID-19, it might be, we've had a patient recently where they're kind of, SATs dropped to 50% by high flow oxygen. Treatment, or reversible causes looked at. And then you then have a box of, is specialist palliative care referral required? So if there are particularly difficult or complex areas around someone's death, then of course put a referral through to us. So you can put yes or no here. And then it also prompts you to say, have you made the referral? And so the referral to us are put through on Cerner. So that would be the first
Can I
box.
check? So if you put yes to the left hand, nothing else happens. It doesn't send it automatically.
No.
Okay.
That would be great, wouldn't it? The next iteration of this. And then it asks you, is the agreement being made in conjunction with the dying person? This may or may not be appropriate, particularly for people dying very acutely of COVID, if they're confused or very breathless or distressed. But ideally, we would have a conversation with them. So you make a comment there. And then if it's not made in conjunction with the patient, has it been agreed with the key family members? And then you write who you've spoken to. The next box is on advanced decisions. So does someone have an advanced decision to refuse treatment? Most people don't, but it's very worth asking, and particularly ask about things like lasting power of attorney. We recently had a case where lots of best interest discussions and decisions have been made, and then late in the day, someone else turned up with lasting power of attorney that nobody knew about. So make sure you check about those things. If you don't know, you can click don't know. Then there's a section on support, so support family members. And then there's a section for your plan, which includes symptom control. So have medications been rationalized? Have you prescribed anticipatory medicines? Is a syringe pump required? And then a review of their interventions. So are you going to continue with antibiotics, monitoring, oxygen therapy, all of those things? Have you thought about food and drink, and has a discussion about food and drink happened with the patient and their family? Do they have a ceiling of treatment and CPR decision? And then there's some after death considerations, and then you sign it off. And if you can't answer all of these questions when you're first filling this out, that's okay. So for example, if you don't have all the details about, do they have an advance directive or lasting power of attorney, or all the details about their family contact numbers, that's okay. Just fill out as much as you can and then come back to those areas. But I think it's really key that we try and use this document as much as possible. It shouldn't take too long to fill in. And And that can be your documentation about end-of-life care. You don't then need to have a separate bit of documentation. Does that all make sense?
That was really helpful. And I've learned a new box, ad hoc.
I know, a new box. A new box and a new template.
Indeed.
Great, so that was the care agreement.
Thank you very much, Sarah. Did you have anything else you wanted to add?
The last thing I wanted to just show you, am I back on my presentation now?
You are?
Great. The last thing I wanted to show you was this communication support guide. And for some reason, my mouse is playing up and won't let me show you the presentation properly, so you may not be able to see this that well. But this was developed by 2 of our consultants last year, and just is a really great step-by-step guide on how you might speak to patients, and has some very key kind of phrases that you could use on the phone. So the kind of green boxes here give you some ideas of phrases that you might say on the phone to someone if you recognise that their relative is at risk of dying. So that might be something else to kind of print off and have quickly available. And the last thing I was going to say, George, is just my takeaway tips. So carry the mini guide with you, practice the anticipatory prescribing and syringe pump. And those of you who are going to be on ARU, so respiratory, medical registrars, people who are on call, do read the CPAP symptom guidance in advance. Everyone, if you could remember the care agreement, that would be great. And obviously call our team if we're needed. Here are the numbers for each of the sites. And then there's always a consultant that's on call after hours and at the weekends. And that is it.